Now we're going to carry on our discussion of how the heart works by looking at how the muscular contraction of the heart is controlled. Now a muscle will contract when it's electrically stimulated. It requires an electrical stimulation. And it's exactly the same in the heart. Heart muscle will contract when it receives an electrical stimulation. Now most muscles need an impulse from the nervous system to contract. But the heart is different from that in that it can generate its own contraction. And if you think about it, this has to be true because patients who've had heart transplants, the heart from the donor will keep beating often for many years inside the recipient without being connected to the nervous system. So the heart generates its own impulse to largely control its own degree of contraction. This is facilitated by the internal conducting system of the heart. It's an internal system which conducts electricity, electrical stimuli, electrical impulses anyway. Now let's look at this system. Now what you'll need to do is draw another basic heart. I've drawn one on here just to save time. So if you haven't got one of these hearts drawn, just have a look at the heart now, the same basic layout that we've used before in this video, and just draw one of those now because you're going to need it in a minute. Okay, now the first part of the internal conducting system is located in the right atria. And in the right atria there's a small area of tissue which generates an electrical impulse. If the heart's beating 70 times a minute, it's because this area of tissue is generating an impulse 70 times a minute. Now this is sometimes referred to as the pacemaker because it sets the pace at which the rest of the heart beats. Its correct name is the Sinoatrial Node. So the Sinoatrial Node, located in the left atrium, generating an electrical current. If the heart's beating 72 times a minute, generating an electrical current 72 times a minute. Now this impulse spreads out across the atria. It's helped by specialist tracts of tissue which are designed to aid conduction of impulses. So the impulse which starts in the sinoatrial node is carried all over the atria via these specialised tracts of conducting tissue. These carry the electrical impulse into all of the atrial muscle, and that means that the atria both contract at the same time. Now, what's important in cardiac physiology to realise is that the plane where the valves are, across the middle of the heart here, referred to in fact as the valvular plane, is made mostly of fibrous tissue. And this will not conduct electricity. So the impulse generated in the atria will not be conducted straight down into the ventricles. There's only one area where the impulse, the electrical impulse, can get from the atria down into the ventricles, one pathway. Because between the atria and the ventricles, just there, there's a second node. And because this node is between the atria and the ventricles, it's referred to as the Atrioventricular Node. So the atrioventricular node between the atria and the ventricles. The only way that the electrical impulse can get from the atria through to the ventricles is via this node. So notice we've got the sinoatrial node, often just referred to as the SA node. and the atrioventricular node, often just referred to as the AV node. And between these two nodes we've got this specialised conducting tissue. So for this reason, these specialised pathways, because they're between the two nodes, are often referred to as the internodal tracts. So we've got the sinoatrial node, impulse carried via the internodal tracts to the atria. The electrical impulses cause contraction of the atria. This impulse can't get through to the ventricles. It can only get through to the ventricles via the atrioventricular node, which picks up the impulse and carries it between the atria and the ventricles. Then, going down the middle of the cardiac septum, there's another area of specialised conducting system tissue which starts to carry the impulse down the cardiac septum. Now this is usually referred to as the Atrioventricular Bundle. It's a bundle of specialised conducting fibres which carries the impulse from the atria down into the ventricles. So it's sometimes called the AV bundle or the atrioventricular. The Atrioventricular Bundle. Again, in some old-fashioned books, you'll see this referred to as the bundle of Hiss, after the man who first identified it. So the Atrioventricular Bundle, AV Bundle, or Bundle of Hiss, it's all the same thing actually. Now the next thing that happens is the Atrioventricular Bundle divides into two other bundle branches. So we have the right bundle branch coming down here and the left bundle branch coming down towards the left side of the heart. Because the idea here is that we want these ventricular walls to start contracting from the bottom up. This lower part of the heart here is referred to as the apex. So we want contraction to start from the apex and move up towards this part, which is called the base. Now, I think you can see that if the impulse went straight into the septum there, that would start contracting from the top. Actually, there is some contraction from the top, but most of the impulse is carried straight down towards the cardiac apex. And then, from the cardiac apex, there's lots of smaller fibres which carry the impulse round about the walls of the ventricles. And these fibres carry the impulse from the right and left bundle branch actually into the myocardium. And these are referred to as Purkinje fibres. Purkinje fibres. So the Purkinje fibres carrying the electrical impulse from the right and left bundle branch into the ventricular myocardium. The arrival in the ventricular myocardium of the electrical impulse is what actually stimulates the contraction of the heart muscle. So we've reviewed the internal conducting mechanism of the heart. It's this which coordinates the cardiac cycle. The impulse is generated in the atrioventricular node, travels through the internodal tracts to stimulate the contraction of the atria, is picked up by the atrioventricular node, transmitted down the atrioventricular bundle to the right and left bundle branches. From the right and left bundle branches, Purkinje fibres carry the electrical activity into the heart muscle of the ventricles, stimulating cardiac contraction. In this section we're going to build on what we've looked at so far, and we're going to look at a cardiac cycle, one complete cardiac cycle. This simply means one complete heartbeat, but we'll look at this in more detail. And we're going to relate this to the ECG, the electrocardiograph. The Americans call this EKG for some reason, but in the UK we call it ECG, electrocardiograph. So let's start off by looking at a normal ECG rhythm. So here we see a normal ECG rhythm detected as electrical activity from the surface of the body and displayed onto a monitor. And you can see here it's showing a heart rate of 80, which is acceptable. Now, to understand why we get this pattern, first let's consider the activity of a single myocardial cell. Now here we have a representation of a single myocardial cell. I know they don't quite look like that, but single myocardial cell. Now, one of the key things about nerve cells, and muscle cells is that they are excitable. This means they have an electrical potential difference across their cell membranes. And when a myocardial cell is at rest, the inside of the cell will be electrically negative. This is just like the pole of a battery. There's a negative pole and a positive pole with a potential difference between the two. And it's the same in a myocardial cell. At rest, it is electrically negative on the inside. So relatively negative charge on the inside. And outside of the cell, relative to that, it's positive. So a positive charge on the outside of the cell. Now these charges are generated by different concentrations of ions on either side of the membrane, and there's a lot of physiology that controls that distribution of ions, but we're not going to consider that at the moment. So let's just accept the fact that relatively negative inside, relatively positive outside. We've mentioned it's a potential difference. It has a voltage. The voltage across the membrane would vary, probably something in the order of 90 millivolts between the two. That's 91,000ths of a volt. So relatively negative inside, positive outside. When the cell is at rest, it's in this state, and we say that in this state the cell is polarized because there's a negative pole inside and a positive pole outside. So polarized. Or the cell is in a state of polarization. Now obviously the whole reason that myocardial cells exist is to contract, to generate the contractile force to eject the blood from the heart. So this cell, to be of any use, needs to contract. And what actually stimulates the cell to contract is the electrical impulse from neighbouring myocardial cells or from the conducting system, which we discussed in the previous section. That stimulates the contraction of this cell. And the way it stimulates the contraction of the cell is to reverse the polarity across the cell membrane to generate contraction. So what happens is, when it's time for the cell to contract, electrical activity will cause depolarization, and the polarity will switch, and the cell will become positive on the inside, negative on the outside. This is the first thing that happens. There's a change of the polarity. And it's this change in polarity across the cell membrane that is the stimulus for the cell to contract. When the polarity changes, the cell will contract. And in this state the cell was polarized. In this state, we say the cell is depolarized. So it's depolarized. The process is referred to as depolarization. So depolarization changes the polarized cell to a state where it's depolarized. And that act of changing the polarity causes the muscle cell to contract. Now we've said that it's the change from the cell being polarised to being depolarised which stimulates contraction. Okay, that's fair enough. But can you see the cell is now depolarised because it's contracted? So if the cell is to contract again in the next cardiac cycle, can you see that it must change from being depolarised back to being polarised in order for it to be able to change from being polarised to being depolarised again to stimulate contraction? So what that means, after the cell is depolarised, it must repolarise again so it's ready to depolarise for the next contraction. So after this happens, the cell will change back to being polarised, a process referred to as repolarisation. So that's the activity in a normal cell. Polarisation at rest. The depolarisation causes contraction. That results in the cell being depolarised. In order for the next cardiac cycle to start, the depolarised cell must undergo the process of repolarisation to become polarised again. Now we've just looked at one single individual myocardial cell. Clearly though, the myocardium contains millions and millions of myocardial cells. And this activity is all synchronised and controlled by the internal conducting system transmitting the electrical impulses from the pacemaker or the sinoatrial node that we looked at in the right atria. So all of these myocardial cells are polarising and depolarising in an organised fashion. And this electrical change, this electrical activity, can be detected on the surface of the body with the electrodes, as we saw on the ECG at the start of this part of the talk. Now, the first thing that happens in a cardiac cycle is the atria contracts. And when the atria contracts, the depolarisation of the atrial cells generates a characteristic wave that can be detected on the surface of the body. And it looks vaguely like this. So the first part of the cardiac cycle is this wave. It's referred to as a P wave. And the P wave is associated with atrial contraction. Now, technically, the P wave is not caused by atrial contraction. The P wave is caused by the depolarisation of the atrial muscle, which causes atrial contraction. But in normal physiology, if the heart's working properly, what it means is the P wave will be associated with atrial contraction. So we normally say the P wave is caused by atrial contraction when it's actually caused by the depolarisation of the atrial muscle. So the P wave we could define as the electrical activity as detected on the surface of the body as a result of the contraction of the atrial muscle. So the P wave, the electrical activity, as detected on the surface of the body as a result of depolarisation, actually the depolarisation of the atrial muscle. Okay, so the atria contract, think back to the diagram, the atria contract, helping the filling of the ventricles. The next thing that needs to happen is the ventricles need to contract. And when there's a much larger mass of ventricular muscle, and when that contracts, the electrical activity detected on the surface of the body looks like this. Approximately like this. We give these waves names. We call this one down here the Q, the R going up, and the S there, the QRS. And we call this the Qrs complex. So the Qrs complex is caused by the depolarisation of the ventricular myocardium. It's the depolarisation of the ventricular myocardium that causes ventricular contraction. So the Qrs complex is associated with ventricular contraction. So the Qrs complex is the electrical activity as detected on the surface of the body as a result of ventricular myocardial depolarization. Now remember, after the muscle has depolarized, before it's in a state where it can depolarize again to bring about the next contraction in the cardiac cycle, it must first repolarize. So after the ventricle is contracted, actually the heart muscle is having a little rest. There's a period where there's no movement, or no contractile movement anyway of the heart. And what you actually see on the ECG is a T wave. It's longer and flatter than a P wave. And the T wave is the electrical activity as detected on the surface of the body as a result of ventricular myocardial repolarization. It's caused by the repolarization of the muscle. It's an electrical phenomena and it's not associated with any contraction. So T wave equals ventricular myocardial repolarization. The electrical activity as detected on the surface of the body as a result of the ventricular myocardial cells repolarizing, ready for the start of the next cardiac cycle. So we've got a P followed by a Qrs complex followed by a T. That's normal. Now you might wonder why we call it PQRST. Well, it's actually completely arbitrary. It's just letters of the alphabet. It could be A, B, C, but we just call it PQRST. That's the way everyone in the world refers to it, so it makes sense that we do the same. PQRST. Let's draw one together now, or try and draw one together. So we've got a P, followed by a QRS, followed by a T, little rest, P, followed by a QRS, followed by a T. It's quite hard drawing these really. P, QRS, followed by a T. Anyway, I think you get the idea. It's not a perfect drawing. And this we refer to as a sinus rhythm. Sinus rhythm because it originates in the Sinoatrial Node. So in a sinus rhythm we have a P followed by a Qrs complex, followed by a T, followed by a short pause. So a sinus rhythm has a PQRST in the right order. And a cardiac cycle begins with the atrial contraction there, when the atria contracts, and carries on through to the equivalent phase in the next complex. So a cardiac cycle is from beginning of atrial contraction to the start of the next atrial contraction. One complete heartbeat. Atrial contraction, ventricular contraction, ventricular repolarization, a short rest phase, and that is the end of the cardiac cycle. That is one single cardiac cycle. So a normal sinus rhythm we can now define. A sinus rhythm consists of a P followed by a QRS followed by a T in the right order, and it's regular. A sinus rhythm needs to be reasonably regular. So a sinus rhythm is a PQRST in the right order and it's regular. PQRST in the right order and regular. And there's one more criteria to define a sinus rhythm. The rate of the heart must be between 60 and 100. So if you've got a PQRST in the right order and it's regular, we have a sinus rhythm. If we have a PQRST in the right order and it's regular, but the rate is less than 60, we define this as a sinus bradycardia. If we have a PQRST in the right order and it's regular, but the rate is over 100, we define this as a sinus tachycardia. So here we have an ECG I actually recorded from one of my students. Here we can see the P wave, the Qrs Complex, and the T wave, followed by a small gap, followed by another P, Q, R, S, T, little gap, P, Q, R, S, T, little gap. So we've got a PQRST. The PQRST waves are in the right order. And the gap between the beats seems to be fairly regular. So we've got a PQRST in the right order, and it's regular, and this rate actually was between 60 and 100. So an example of a sinus rhythm as detected from the electrical activity on the surface of the body. So let's now summarise the three normal heart rhythms we talked about. First of all, sinus bradycardia. PQRST in the right order and regular, but the rate less than 60. Less than 60 beats a minute. Now, one of the things you need to decide in the clinical situation is what is the appropriate heart rate for an individual. Obviously, children, babies, have very high heart rates compared to adults. Children have higher heart rates than adults. But for adults that are fit, then sinus bradycardia could be their normal rhythm, because when people are very fit, often the heart rate is lower. Or alternatively, when adults are at rest or asleep, then again it's fairly common for their heart rate to drop below 60. So depending on the context, sinus bradycardia can be quite normal. Sinus rhythm. Well, sinus rhythm we described as a rate between 60 and 100. Which is quite normal for adults. Between 60 and 100 is the normal rate you would expect. Now, if the rate goes over 100, we define that as a sinus tachycardia. In a sinus tachycardia, the rate is greater than 100. Still need a PQRST in the right order and regular, but the rate is over 100. And of course, sinus tachycardias are quite normal during exercise, when cardiac output needs to be increased to meet the increased metabolic demands of the muscular system. So three normal heart rhythms, depending on the context of the individual: sinus bradycardia, sinus rhythm, sinus tachycardia.